Okay, hello everyone. Hi Namrata, Jiwan, Mahinda. Thank you so much, Mahipal. Thank you so much for inviting me to join this wonderful AIOS session. Well, I'm going to be sharing with you my thoughts on the IOCT imaging of really mainly the lens capsule. And Namrata, I know you made a presentation on this a day or two ago, and I'm sorry I missed your talk. I hope I don't overlap with you too much. But I've been having such fun really learning about this new imaging technology during cataract surgery. So I thought I'd just share this with you. Now, the IOCT is actually a lovely instrument. We can see, as you can see here, the anterior capsule beautifully. You can see the anterior cortical cataract beautifully. And if you focus behind, we can see the posterior capsule and also the posterior subcapsular cataract very nicely. I also love these images of live hydrodissection, and you can see here the fluid wave coming in here on the right, really showing us the different layers of the lens. And I mean, we're still learning about this new technology and what all these things actually mean. Here's a patient with a phaco tip in the eye. You can see there's a layer of cortex on the posterior capsule, which was being pushed back. Now you see that the whole posterior capsule has come forward through the holographic image of the reverse cornea. You can see that the posterior capsule is bulging forward, but when I put the IA tip in on the left, you can see that the posterior capsule now bulges backwards with that layer of cortex. So really the technology is pretty good at imaging the posterior capsule as well, as long as the lens is reasonably clear. I mentioned that earlier, that in a very dense opaque cataract, it's sometimes hard to see the deeper layers, but when you've taken out the cataract, it's usually quite easy. Now, I think just now we talked a little bit about how important IOCT is, and I don't think we're there yet, but I think that it is going to be more and more useful, certainly in teaching institutions, for teaching residents, things like how deeply to sculpt the nucleus, what the incision structure looks like when you're using OCT. It's also pretty useful in doing research, like looking at the IOL capsular back relationships, whether to remove OVD or not. But really, it's in the field of as a surgical aid. Is IOCT any use as a surgical aid? And I actually particularly wanted to look at posterior capsule ruptures. Now, some of you may not know what a PCR looks like. I teach many residents, so I have a pretty regular view of PCRs. But my IOCT, unfortunately, was in my private practice. So and I wanted to sort of image what the OCT view of a PCR was. But so for the last few years, I didn't have a PCR, so I had difficulty imaging the PCR. So finally, I had a case in which I decided to do a primary PCCC because the posterior capsule is very dense. And I thought this way I could image what a posterior capsule rupture actually looks like. So here's my needle, just making a simple tear in the posterior capsule and turning on the live OCT here on the right. Once we've done that, and we should see here, now you can see actually the posterior capsule defect is beautifully shown here, and we can see that the edges of the defect are both turned backwards, beginning to fold back on itself. And so I was very pleased that we can actually see that. And here the wavy line behind is actually the hyaloid face, but we can actually see the posterior capsule rupture quite well. So, and when I got that, I was saying, gee, okay, now I know we can see the posterior capsule. Let's wait for a real PCR rupture to happen. And of course, having commented that I haven't seen a PCR for a few years, then I had a run of a few. Let's look at this case in which I'm injecting a toric lens into the eye. So the toric lens has gone in, and I always go behind the lens to remove OVD. And here you can see my IA tip has gone behind the lens. I'm just aspirating gently. I'm really not doing very much. And then as I come out, I see that line there. Can you all see that line diagonally across that? I don't know about you, but I feel I never get PCR. So surely that can't be a PCR. I mean, I didn't do anything wrong. So I put the lens in anyway. And by this time I realized that it was a PCR and I've captured the lens. But here we can see that I've done an anterior optic capture. So one use of the OCT is that the optic is behind the anterior capsular leaf that you see there. And then I'm going to bring the OCT over to that diagonal line behind the lens to see if we can see it. And here you can see the sign that I'm talking about. You can see that there's a scroll, that the posterior capsule, the edge of the PCR kind of curls up like a little scroll there. Okay, and if you notice that what I showed you just now with the anterior capsule, because you've got a nice round anterior capsular CCC that's intact, the edge doesn't roll. The edge is actually completely straight. But when you've torn the posterior capsule, you get this scroll-like image. Having got that one, shortly after that, here's another one. Okay, I think this was actually the new synergy lens that I was putting in. I was also going in behind the lens to remove the OVD. And if you can tell me why this capsule ruptured, you know, I'd be very grateful. So I was just aspirating behind, come forward, and there's another line, okay? You see that line there? There's a line up there just under my IA tip. Again, I thought, gee, wow, you know, good things certainly don't come alone. So, you know, looking at that, you know, I put the lens in, and I'm just turning on the OCT now. Now, this one's a lot more subtle than the previous case. Where you look here, on the bottom right, you see there's that little scroll, that little curved edge. Now, using the OCT to image structures deep in the eye is sometimes challenging because of the focusing required and so on and so forth. Now, here, I think we can all see clinically that that's a PC rupture there. And here, if you look carefully, there's one edge of the rupture at the top and another edge where that scroll edge is at the bottom that shows the other end of the capsulorhexis. I think most of the times when we see a PCR happening in front of us, we know it's a PCR. But, you know, I think this is, again, a useful tool to show our residents as well that this is what's actually happening in the eye. So this is my second case after the deliberate posterior capsule tear that I made. And here again, you can see that little defect, that's the edge of the PCR, I mean. So here, so the sign I'm going to call it really is the OCT scroll sign of a PCR, which I think is a useful thing to have if you're not sure that what you have is just a wrinkle or a stress line in the posterior capsule, or is it really a PCR? So let me show you this third case, which is actually very interesting. This was a 53-year-old man we saw recently. He and his friend had been rock climbing, and they disturbed 3 bees' nests. And they were attacked by this swarm of bees. And in fact, his companion died from the bee stings. He himself was stung all over the body and eyes. And actually, he had to go into ICU because of multi-organ failure. One eye, the right eye, was blinded because of the bites in the eye, stings in the eye, and the left eye was also stung. His cornea started melting, so they put an epithelial patch graft on it. He had endophthalmitis, and they did a vitrectomy on him. And of course, after that, he developed cataract and came to see Donald Tan for the cornea. And then Donald asked me to help him with the cataract. So this patient, you can see here, that's where the cornea was melted and epithelium was there. And excuse me, you can see that it's a dense white cataract here. And, you know, I got a good capsulorhexis. And as I was doing the phaco, I noticed that the consistency of the cataract was nothing like a normal soft heart or neither here nor there nucleus that we're so familiar with. This cataract was sticky and gooey and stuck to the capsule, and it really was stuck to all the other structures around the lens capsule. And it was a challenge. I thought this would be a simple aspiration of the cataract since it was just a 50-year-old. So being patient, I eventually managed to clear most of the white cataract away. And at the end, I'm just doing my IA of the last bit of cataract. The view isn't great because this quadrant of the cornea is hazy from the cornea melt. And then I see that line there. Do you see that line distally there? Now, Donald's sitting with me because he's looking at the cornea. And then he said, I think that's just a wrinkle. I think it's a PCR. Donald says, no, I think it's a crease line in the posterior capsule. I said, well, let's turn on the OCT and see. If you look down here, you will see there's the scroll here on the bottom right image. So the use of the technology was useful, especially if your view of the posterior or of the posterior capsule is compromised. So I put in a 3-piece IOL, and this is thanks to David's teaching, of course. You know, many a times when you've got complex cases like that, putting a 3-piece lens with the haptics in the sulcus helps, and I captured the optic in the bag, and you can see from the OCT image that the anterior capsular lens is in the bag there. So that's the end of that particular case. So it was very useful in confirming the presence of the PC rupture and also the position of the optic in the capsular bag. So just to repeat again, this is the scroll sign of PCR seen on the IOCT. Now, how do you distinguish that from just a crease line? Now, here's a crease line, or at least I think it's a crease line, or is this a PCR that we often see after an IOL has gone in the eye? The difference is, if you see this fold or this scroll here, it's continuous. You can see the line going all the way across the back of the lens in a wavy nature. And the other things you see, I'm putting the cannula on the left, and when you press, those crease lines disappear. And you can see that those scrolls have been flattened out by the simple maneuver of just pushing down gently on the IOL, and confirms that this particular diagonal line was not a PC rent, but just a crease line from the IOL haptics. So just to end with again, this is the OCT scroll sign of PCR, and I think that the IOCT is a pretty useful surgical aid. It helps us confirm PCR in those cases where we're not absolutely sure, and it also helps us confirm that the optic has been captured, whether it's anteriorly or posteriorly in the position that we would like it to. Just a reminder, I'd like to invite everybody to join us in our virtual APA CRS meeting in July this year. And thank you very much for having me here again.